I will discuss the fetal monitoring in the labor. That is a nice guideline which is released in December 2022 by the Royal College of Obstetricians and the gynecologists, right? And then I will also discuss for the newcomers who are appearing in exam in July 2024. I will discuss with them that how we can prepare very effectively in exam so that we can pass the exam in a one go, right? So first of all, let's start this guideline. Okay, all right. So in this guideline, actually, there are many things which we need in MRCOG Part 3, and there are many things which we need in MRCOG Part 2, right? So mostly I will be covering all the things. First of all, coming to this slide, I will be telling all the questions which will be coming, and I will be covering all the answers as well, so that it will be easy for you to attempt the EMQs, because you know that this guideline will be coming in the EMQ questions, right? Very less chances that any single best answer can come from this. But still, let's go ahead and let's start. Take a very good start for this. And thank you so much for all of you again for joining here. So coming to this slide, first of all, shared decision making. Shared decision making, actually a new thing that has been entered in this guideline, because it was not there previously. Now it has entered in this guideline as well, and in the labor care guide as well, because now you cannot recommend any option to the patient in MRCOG Part 3 exam as well, that this option is suitable for you, this option is suitable for you. You just discuss with her that these are the options, and what is best for her, she is the one who will decide, right? So this process is actually called shared decision making. So what we have to do, we have to discuss the option of with the patient. We have to discuss just a minute. Yes. We have to discuss the fetal monitoring option with the women, document this and the discussion and decision in her pregnancy care plan. Not only the discussion is included, but also we have to document, because in the options, when the many options are given and there is the option of only discussion is given, you cannot choose the option of discussion. Discussion, then documentation of the care plan, discussion plus documentation. These two are very important. Then what you have to do next, you have to support the woman's decision about fetal monitoring during the labor, right? You have to support whatever decision she will take. You have to support the decision. Whether this decision is good for her or this decision is bad for her, you are no one to decide that you are going to provide her or not. You have to support her. This is the ultimate rule. Don't forget this rule. This is very important for Part 3. Even many students get fail in the MRCOG Part 3 because they are feeling that patient is asking for something which is not good for her. Okay, keep the women informed about if additional advice is being sought by the team. Whenever there is information which is changed, you have to tell the patient that, yes, now we are managing another plan for you. So general principles: perform and document the systemic assessment of the condition of the woman and unborn baby. Fetal heart rate monitoring is a tool to provide guidance on the fetal condition only, not a standalone diagnostic tool. It means that in the scenario, when you see there is some CTG has been given, there is some monitoring pattern has been given, it does not mean that you have to decide only on the base of that CTG. You have to take the whole clinical picture along, and then you have to make the management plan, right? If in the exam you see the CTG, you're not understanding that what is it all about, what is it variable deceleration, it is late deceleration, you're not going to bother by that. You have to read the scenario, and then you have to pick the management plan. The findings need to be looked together with the developing clinical picture for both mother and the baby. Now, what are the methods of auscultation, right? I'm sorry for interruption, but please, MRCOG, help my support. Please write all on the study groups as well, so that other people, if they're waiting, they can join, please. Thank you, Isha. Thank you so much. Okay, so the auscultation, intermittent auscultation, the methods which from which we can measure the heart rate of the baby is that intermittent auscultation and the continuous monitoring, right? So what are the indications for the intermittent auscultation? When we will do in the first stage of the labor, and when we have to do in the second stage of the labor. And please, the participants as well, give them the opportunity so that they can unmute their mic and they can ask me as many questions as they want, please. Okay. Hello, am I audible now? All right. So shared decision making has been discussed, right? Now, intermittent auscultation. When we have to do the intermittent auscultation, what should be the frequency of intermittent auscultation, right? In the intermittent auscultation, in the first stage of labor, just remember this can come as a single best answer question. The tools that we use for the first stage labor monitoring is the Pinard stethoscope and the Doppler ultrasound, right? These are the only two methods. In the first stage of the labor, for the intermittent auscultation, Pinard stethoscope and Doppler ultrasound. Friends, in this session, I want to make this guideline super easy for you. No unnecessary details which are not required for your exam, because otherwise you know that for the fetal monitoring, we can speak a lot of hours, but this is not required, right? So I will be only pinpointing those points which are important for your exam perspective. Okay, by using the Pinard stethoscope or the Doppler ultrasound. And when you will do the intermittent monitoring, after a palpated contraction for at least 1 minute, it means when the contraction will over, then your minute will start. After the contraction end, then your this 1 minute will start, and this you will repeat it after every 15 minutes, 15 and 5. In the first stage of labor, since when the first stage of labor will last? For the 10 centimeter. So when the dilatation is up to 10 centimeter, you have to do after every 15 minutes. After fully dilatation, then you will do the monitoring after every 5 minutes, 5 and 15. In the second stage, every 5 minutes, and in the first stage, every 15 minutes, right? So can you unmute your mics now? Okay, all right. Can you unmute your mics, friends? Okay, all right. So first stage of the labor, after the contraction for 1 minute and every 15 minutes, right? Every 15 minutes. And in the second stage of the labor, intermittent auscultation, immediately after the palpated contraction, let the contraction to get over. After the contraction will get over, then you will do for complete 1 minute. It's not like you will do 30 seconds and then you will double it up. You will do 15 seconds and then you will multiply it. It will not be like this, right? For the whole 1 minute and after every 5 minutes, 5 minutes, 15 minutes, 5 minutes, and record it as a single trace on the partogram. And in the women's note, single trace means that in 1 minute, whatever you will not document it like it will be 140 to 150, it is 160 to 170. You will not write like this. You have to write it a single trace. It is 140 beats per minute, because intermittent auscultation, when it is recommended by this guideline, it means it is a significant, right? Okay. Yes. Yes, just a minute. Okay. Now there are indications for the continuous CTG. These are very important because let me tell you, Rekha, Yusra, and the Sana, listen to me. When in the scenarios, you are going to see in the exam that any of this has been mentioned in the scenario from these 10 points and from these 9 points. Any of these points have been mentioned in the scenario. In the options, you can see that there are different things have mentioned. Then you will pick up the only option where the CTG has also included, because usually the candidates feel that any of the risk factors are not very important to remember. But let me tell you that these risk factors are very important to remember, because if you will be knowing all this, then you will choose the option of the CTG, right? And in the CTG or in the intrapartum question, there are many things will be written. So you have to choose the option in which CTG has also been mentioned. So what are the antenatal risk factors which are indicated in which there is, we have to do the continuous CTG. Now, no intermittent auscultation in all these conditions. In all these antenatal conditions, in all these intrapartum conditions, there is no way to do intermittent auscultation, right? Now I will make it easy for you that how you have to remember these. First of all, in antenatal period, just bring the thoughts in your mind and just do a brainstorming that what are the risk factors which can lead any patient to the any complication during the labor. It will include many of the medical disorders, right? Like hypertensive disorder, type 1, type 2 diabetes. These two are medical disorders, right? This is done. The option 2 and option 6 have already been memorized. Now, anything which is related with rupture of membrane and its infections, like prolonged rupture of membrane, what will happen when there is a rupture of membrane, vaginal loss, right? So any vaginal blood loss other than the show is normal. Any vaginal blood loss other than the show, it will again come in the CTG category. Suspect what will happen if the membrane will be ruptured for the longer period of the time, chorioamnionitis and then sepsis. So these three indications you have to remember together: prolonged rupture of the membrane, vaginal blood loss other than the show, suspected chorioamnionitis and sepsis, right? These three are together. These hypertensive disorder and type 1, type 2 GDM are together. You have to remember, I will make sure that after leaving this session, these things will be on your tips, right? And then fetal growth restriction and hydramnios and reduced fetal movement. These three, if you feel that these three are related with each other, whenever the baby is smaller than gestational age, usually the liker is less, right? And the fetal movements will also come. Many patients came to us with a reduced fetal movement. When we do the scan, their liker is reduced, they're having fetal growth restriction. So all these are also connected with each other. These three are connected with each other. These two are connected with each other, and these 3, 4, and 5, these are also connected with each other. And previous scar and any uterine scar, you already knowing that this is a risk factor, right? Now, what are the intrapartum risk factors that are very important to know that can increase the risk, and that is a proper indication for the CTG? Okay, all right. When the contractions that last longer than 2 minutes or 5 or more contraction in 10 minutes. Okay, guys. Now you have to remember these two figures, very, very important. Contraction that last longer than 2 minutes. This 2-minute figure you have to remember because it is coming in the next few slides, and I will tell you that what is its significance. And 5 or more contraction, it include 5. It's not more than 5, friends, it include 5. 5 or more contraction in 10 minutes. What is the half of 10 minutes? 5. So 5 or more contraction, or a single contraction which is last longer than 2 minutes. Maybe she's having only one contraction in 10 minutes, but that one contraction is lasting longer than 2 minutes. So in this case, this is an indication to go for the CTG because blood supply of the fetus is getting compromised because of these contractions. Presence of meconium. Now just come to the scenario that if in the scenario there is meconium stained liquor, right? There is meconium stained liquor. Now for the meconium stained liquor only, this is not a thick meconium, what you are going to choose? Any of you, can you please on your mic and tell me that?
Auscultation.
Yeah, exactly. Rekha, if BMI more than 35, we do continuous CTG or intermittent auscultation. Rekha, actually, it has not been mentioned over here in the indications, right? But this
Ma'am,
is
in the
mentioned.
GTG, it was mentioned that intermittent auscultation. That's why I want to confirm.
Coming to that point. Exactly, you're absolutely right, Rekha. Listen, whenever there is any situation in which fetal hearts are not audible properly, then definitely you have to go for the continuous CTG. But when fetal hearts are audible at the BMI of 35, there is not an indication for continuous CTG, right? Am I clear now?
So it means if in the exam the scenario will be there, then we choose the intermittent auscultation.
Ah, it has not been mentioned over here. But listen, they have they maybe put some other things as well. It will not only be the BMI of 35. This is the reason I'm saying that whole scenario, read the whole scenario. Then you have to figure it out that what is exact you have to choose. At the end of this discussion, you will be having a very clear idea that what you have to choose, right? Just keep the flow with me. Okay, I have told you that meconium. What are you going to choose in the meconium?
It will depend upon the grade. If it is thick meconium,
previously,
then we
Rekha, listen, my dear. Previously, it was the matter of grading, but now it is no grading. Presence of meconium, they have not told, they have not, the thing which has not been mentioned in the guideline, it means we are not, we're not making our own theories. We are not making our theories from our clinical practice. Yes, this normally, not only you, I also used to do this. Yeah, this is a very light meconium. It's not significant at all. But what they have told us, we have to follow it because you have to clear the exam, right? So for the exam, just remember all these things. We have to follow all the guideline in the exam. Now, maternal pyrexia, remember 38 and 37.5. These two figures should be on your tips. These digits, I will make sure that the end, these will be in your tips. Contraction, 2 minutes duration, and 5 or more contraction, right? And then temperature, 38 degrees Celsius on a single reading or 37.5 on the two readings 1 hour apart. because this is less, right? 38 is more. This is the more pyrexia. So these are also indication because mother is getting suffered. Mother is having infection, some sort of infection is going on. This is the reason. There is some rationale for all of these indications. Now, suspected chorioamnionitis or sepsis. This is also some infection is developing on, right? Now, these are also very related. In the labor, you will see that many things are related with the liquor. Chorioamnionitis, sepsis, pain, which is different from the normally observed in labor. It means that patient is in labor, she was having normal labor pains, but suddenly her pain become excruciating and very severe. It means you have to shift her from intermittent to the continuous CTG, right? You are not going to do intermittent now because maybe in the scenario they have written that patient is having excruciating pain, like pain is not waning off. So you will not consider it as a regular labor pains. Then fresh vaginal bleeding, blood-stained liquor. These all are related with the liquor and sort of infection sort of things, right? Blood-stained liquor. Maternal pulse. These is again infection. Maternal pulse 120 beats per minute on 2 occasions, 30 minutes apart. Severe hypertension, right? It means in the severe hypertension, blood pressure of 160 mm of mercury or diastolic of 110, 160, 110 BP or 140, 90 on 2 occasions, right? 140, 90, 2 readings are required. 160, 110 because it is already very significantly raised blood pressure, so 1 reading is enough. Or a single reading, 140, 90, it means there are 3 points related with the blood pressure. 1 point is that 160, 110 BP. Other is that 140, 90, 2 readings. Other is that third point is that 140, 90 with 2 plus proteinuria. So 3 points are related with the raised blood pressure, right? Then confirmed delay in first or second stage of the labor. Shortly in next few days, I will be taking another class for the intrapartum management in which I will explain you that what is suspected delay and what is confirmed delay. So they have not written here suspected delay. They have written here confirmed delay, right? After 4-hour examination, when you do vaginal examination, you see that there is a delay. This is a suspected delay. Then after 2 hours, you will do further vaginal examination. Then that is a confirmed delay, right? Do not confuse it with a suspected delay. Confirmed delay in first or second stage of the labor, regional analgesia, use of oxytocin. Syntocinon has been started, you have to start CTG. Anyone can tell me that what is the other prerequisites of starting the oxytocin? Whenever in the scenario you are starting the oxytocin to the patient, what 2 things you have to choose? If anyone can unmute and tell me that what are...
Epidural, ma'am.
We need to rule out
Perfect. That is wonderful. I cannot actually, I have placed the chat on one side. Can you tell me who has told me that epidural?
Ma'am, Monica.
Monica, wow. Welcome, Monica, on our session. And thank you so much for joining in.
Thank you, ma'am.
It's a pleasure to have you over here, right?
Thank you, ma'am.
All right, this is the best answer. I was like, it usually it's quite difficult because people usually take it very casually, right? So whenever oxytocin is there, you have to choose CTG and you have to choose the analgesia. Now, who is going to repeat 1 or 2 or maximum 3 options of intrapartum indications for the CTG? Please come up, come on, join with me, guys, because this is not a one-sided lecture. We are just friends sitting together.
Ma'am, wherever there is the presence of meconium and pyrexia of 38 degree or 37.5 or 2 times, and whenever we find out the 3 readings related, like to blood pressure related 3 indications we read, like the 160 by 101 reading and 140 on 2 readings and 1 reading where 140 by 90 plus proteinuria of +2, and whenever we are using epidural oxytocin.
Wonderful. Anyone want to add something in the intrapartum indications?
Yes.
It was wonderful answer. Anyone want to add few more indications?
Ma'am, regarding the previously we read about that one also. Fetal growth restriction, anhydramnios, polyhydramnios.
Yes, that is in the antenatal, my dear. Just keep them separate, antenatal and intrapartum, right? And anyone who want to repeat the antenatal indications? antenatal indications, my dear. Like I have told you, medical disorders. 2 were the medical disorders, right? And 3 were the prolonged rupture of the membrane related, right?
Yes, ma'am. Hypertension, diabetes,
Hypertension,
and
diabetes, combine these 2, and these 3 are
medical.
rupture of membrane,
Mm.
any vaginal blood loss. What happened after the rupture of membrane? Chorioamnionitis, right? And then what happened when the baby was anyone having reduced fetal movements? Usually fetal growth restriction is there, and anhydramnios. So combine these 3 together, right? In this manner, it will be easy for you to remember. You will not need to open again and beginning to cram it up, right? Thank you so much for Okay. Now coming to the presence of meconium, this was always the point of controversy in many questions. But as I have told you, friends, that we have to follow the guideline only, right? Now they have what they have mentioned. Consider the character of meconium as a part of overall clinical assessment in conjunction with other antenatal or intrapartum risk factor and discuss the option of CTG monitoring with the woman. It means that they have given you a lot of open hand. You can make your decisions. They have told you that character of the meconium, you have to combine it with the clinical assessment of your intrapartum risk factor that you have previously read. These are antenatal risk factor and these intrapartum. You have to combine these with the meconium, and then you have to discuss the option of CTG monitoring with the women, right? And recognize the type of monitoring methods used in the women's choice and support her in decision. Friend, let me tell you that you have to cram these lines, not only for the part 2. You have to cram it up for the part 3 exam as well. And time of cramming up is this, only the part 2 exam. In part 3, you will not get enough time to cram it up anything, right? So because you have to take the risk factors in the scenario, then you have to discuss the options with the woman, and then you have to support her decision, whatever decision she's taking. Now, the presence of meconium can indicate, what is the meaning of the presence of meconium? It indicates possible fetal compromise, right? And may lead to the complications such as meconium aspiration syndrome. Now, meconium is a common in the postpartum. In the postpartum scenario comes and there is a meconium, you will not say that, yes, in the postpartum, it's quite casual and it's quite common to have meconium, so this is not need to bother. No, not at all. Meconium is common in the postpartum, but still trigger full risk assessment. In the next few slides, I will be telling you what this exactly mean, the full risk assessment, right? And the discussion with the women about the option of CTG monitoring. Okay. Now, features of the CTG. Now, friend, there are 2 things basically. You have to remember few things. One is the feature of the CTG and other is the characters of the CTG, right? Categorization of the CTG, sorry. So the features of the CTG is another thing, categorization of the CTG is another thing, right? Whenever you have to, so this is that we have decided and we have divided the CTG into 2 parts. First of all, we will learn the features. Then based on those features, we will learn about the, just a minute, then we will learn about Dr. Breen is here with us. Am I right? Thank you so much for joining in, my dear. Thank you so much. It's so good to see you here. It's my pleasure. Okay, all right. So coming to the features of the CTG, these are the contractions, baseline fetal heart rate, right? And variability, deceleration, acceleration, right? So I will be discussing all these features first, and then we will go ahead with the categorization and how we are going to choose the management options among the management plan, because that will be the question which is coming in the EMQs. Features, you are everyone knowing that contraction is a feature. So use of tokodynamometer to record the contraction frequency and strength on the CTG trace. What we have to record about the contractions, its frequency and strength on the CTG trace, right? Okay. Just a minute. Hold on, guys, just a minute. Okay, all right, my friends. So let me start the chat box as well. Yes. Yes, coming to the contractions first, right? For the contractions categorization of the CTG and its contractions. So what are the types of contraction? How we can categorize the contractions? That is the feature of the CTG. Contractions can be categorized as white, right? Or it can be categorized as amber. When we have to categorize them white and when we will categorize them as amber. We will categorize them as white. I have written in the slides in the white color so that you can take the screenshots and that will be very easy for you to remember. White will be the contractions when there are less than 5 contraction in 10 minutes. So less than 5, what does it mean? 4, 3, 2, 1, right? These contractions will be included in the categorized as white. When there are 5 or more contractions in the 10 minutes, that will be included in amber, right? 5, when the word of figure of 5 is added, it means it's the amber categorization of the contractions. This is the only one feature of the CTG. We are discussing the features of the CTG, right? After the features, then we will discuss how to categorize the whole CTG. So amber means 5 or more contractions in 10 minutes, or there is hypertonus. What is the hypertonus exactly? Hypertonus, as we have already discussed about it, that a contraction lasting 2 minutes or more, right? If 5 or more contractions per 10 minutes are present, perform full risk assessment. Full risk assessment means antenatal risk factors, intrapartum risk factors, current vitals of the patient, current vaginal examination, all is included in the full risk assessment, right? Take action to reduce the contraction frequency. Now, what action we can take to reduce the contraction frequency? Sometime one of the students have asked me that, ma'am, is it possible that when the syntocinon and oxytocin has been running on and we stop the labor and we stop the contractions? Yes, we can stop. We can reduce the contraction frequency. Conservative measures, in the next few slides, I will be telling you in detail and explain the woman what is happening and ensure that adequate pain relief is present, right? These are all the steps we have to take when the contractions are 5 or more contractions in 10 minutes. Anyone can repeat, please? What are the amber features of the contractions? Hello? Anyone can unmute your mic, please? Hello, hello, friends, please. Okay, all right. Isha, please, can you post in the group that we are back in the session?
Ma'am, the contraction should be less than 5.
Yes, exactly. When it is less than 5, it is white. When it is 5 or more than 5 contraction, then it is amber, right?
Amber.
Yeah, and when 2 minutes, you have to remember that figure as well. Now the baseline fetal heart rate, what is called exactly the baseline fetal heart rate? See, these are the D cells, right? These are the D cells or accelerations, whatever there is. But what is the mean fetal heart rate? You have to remember the word mean fetal heart rate, because in the part 3, you are going to attend the session where you are going to teach the CTG for your junior, right? At that time, you have to see that what is the mean fetal heart rate. So what is the mean fetal heart rate? This is the mean fetal heart rate. The mean fetal heart rate is the baseline fetal heart rate, right? Excluding acceleration and deceleration over a period of 10 minutes when the fetal heart rate is stable, right? Now, how we will categorize the baseline fetal heart rate? Just take the screenshot of this guideline, this slide that I have make them in a color of white, and although this is not amber, and then red. White means the stable baseline of heart rate of 110 to 160 beats per minute, right? You can count from here. This is 90, this is 120, this vertical line is showing the fetal heart rates, and this horizontal line is showing the time. So the stable baseline of 110 to 160 beats per minute, and the amber is that when increase the baseline in the heart of the fetal heart rate is 20 beats per minute or more from the start of the labor, 100 to 109. When 110 and it to 160, it is stable baseline. When it is less than 110, it is up to 100, it is in the amber. or it is up to 100 to 109, right? It has not reached the 110. It is less than 110. It means it is amber. And red is that less than 100 and more than 160. It is very easy to remember, right? Less than 100 and more than 160, it is red. 100 to 109, it's amber. 110 to 160, it is white. Okay, so can I see that? Yes. Okay, all right. So Monica, are you with me?
Ma'am.
Okay, all right. Can you please revise with me? What are the white and amber?
The baseline heart rate being 110 to 160, that is white, ma'am.
Yes, that's
Amber is
excellent.
100 to 109 is amber, or increase in baseline more than 20 from the previous reading. And red will be less than 110, sorry, less than 100 or more than 160.
Yes. Okay, all
Thank you,
right.
ma'am.
All right. So, yes. All right. Then comes here, the baseline fetal heart rate is usually between 110 and 160. Lower the baseline fetal heart rate is expected in the postterm pregnancies, right? And higher the baseline fetal heart rate in the preterm pregnancies. Rise in the baseline fetal heart rate may represent either developing infection or hypoxia. Whenever baseline fetal heart rate is rising, it means there's some sort of infection or hypoxia is going on. If the fetal heart rate is between 100 to 109 beats per minute, continue the usual care if other features are normal. In many scenarios, in many practice books, 100 to 109 baseline has been given, and many people are choosing options of going here and there. But let me tell you that option is only continuous usual care. We are not going to do any intervention between 100 to 109 if other features are normal, right? Between 100 to 109, we are not going to choose any other thing. Then comes the variability. Determine the variability by looking at the minor oscillation in the fetal heart rates, usually occur at 3 to 5 cycles per minute, and measured by measuring differences between the highest heart rate and the lowest heart rate in 1 minute segment of the trace between the contraction, excluding decels and accels. Let me explain it further. Right, these vertical lines, these are showing the amplitude of the CTG, amplitude of the variability, amplitude of the any heart rate, right? So we will count from this line to this line. If it is 10 beats per minute, if it is of 10 beats, like it is starting from 120, 130, 140, 150, right? 120, then 121, 122, 123, 124. It's a 5 beats per minute. It is 20 beats per minute. We have to see that variability is up to 5 to 25 beats per minute. It will be showing in the next few slides, right? So it's usually occur 3 to 5 cycles a minute and measured by difference between the highest heart rate. This is the highest heart rate and this is the lowest heart rate, right? So this CTG is showing the reduced variability. You can see that there is variability, or everything is just going in the straight line. So this is the variability is reduced. Amplitude is very less. It is almost finishing in less than 5 beats per minute. Like it's 140, 150 is in between, and then there is a 160. So it's around 151, 152, 151, 152. So this is the reduced variability, right? Okay. How we will categorize the fetal variability? We will categorize the variability by white, amber, and then red. In the white, there are 5 to 25 beats per minute. In the amber, there are fewer than 5 beats for between 30 to 50 minutes, or more than 25 beats for up to 10 minutes. Now, how you have to memorize it? First of all, you have to memorize 5 to 25 beats per minute, right? This is white. Then how you have to memorize the amber? It is less than 5. This is 5. Just remember these two words, right? 5 to 25. Less than 5 beats per minute for between 30 and 50 minutes. If you add 0 in front of 5, it will become 50, right? So less than 5 beats per minute for 30 to 50 minutes, or more than 25 beats per minute for up to 10 minutes. Usually, you will not see this scenario in exam. Like this will not be more than 25 beats a minute for up to 10 minutes, because there is very less chance that CTG will be, variability will be more than 5 beats. But less than 5 beats, like I have shown you in the previous slide, that reduced variability will be very frequent scenario in the exam for between 30 and 50 minutes, right? Now, what will be the red features? Fewer than 5 beats per minute for more than 50 minutes, and more than 25 minutes for more than 10 minutes. 50 and 10, 50 and 10, right? Less than 5 beats for more than 50 minutes, more than 25 beats for more than 10 minutes, or sinusoidal trace. So friends, is it easy now? Okay, all right. Okay, Rekha, welcome again.
Thank you, ma'am.
Yeah, Rekha, we were telling about white, amber, and red. In the white, there are 5 to 25 beats per minute variability. In the amber, there are less than 5 beats per minute for up to 30 to 50 minutes. So just attach 0 along with 5, it will become 50. And more than 25 beats per minute for up to 10 minutes only, right? 5 beats for up to 50 minutes, 25 beats for up to 10 minutes. I was already telling that 25 beats is less likely that you will see. And fewer than 5 beats for more than 50. Here up till 50 minutes, here you will say more than 50 minutes. Here it is up to 10 minutes, here you will say more than 10 minutes. So remember just these two figures, up to 50, up to 10, more than 50 and more than 10, right? Anyone can revise with me, please?
5 to 25 is white, less
Yeah.
than 5, but between the 30 to 50 is normal, means amber. More than 25, but up to the 10 minutes is amber. But if it is more than 10 minutes, it will be red. And 5, if less than 5 beats, more than 50 minutes, it will be red.
Yeah, knowing these things are very important, Rekha, because in the exam scenario, they will only be telling you that the CTG pattern will be given, or they will be writing that this much feature is amber and this much feature is red, right? Now, the reduced variability may lead to there are certain conditions which lead to the reduced variability and the decelerations. Coming to the decelerations, right? Decelerations are not as much confusing as usually looks like. It is pretty simple because you have to exclude few forms of the deceleration completely for your exam. Don't remember them, right? You do not need to remember early deceleration because you have nothing to do with that. Your management plan is not going to change with early deceleration, so don't need to remember them. Do not bother a lot of information. Deceleration is actually a transient episode. Actually, this is the definition which is taken from the NICE guideline. You have to remember these things for MRCOG Part 3 when you're teaching your student. There is a teaching station for the CTG in Part 3 in which you have to tell that these early decelerations are the repetitive, periodic slowing of the fetal heart rate. This is slowing of the fetal heart rate with onset. Onset means start. When it is starting, this is the early deceleration with onset early in the contraction. This is a contraction, it is starting, and it is starting early in the contraction and return to the baseline at the end of contraction. This is the contraction. When it is ending, it is reaching back to the baseline. This is the baseline, this is the baseline. So this is the basically early deceleration, which you all know. I know that you guys are very expert in it, that this is the mirror image of the contraction. Everyone knows this, right? So it is fall in the baseline fetal heart rate of 15 beats per minute, and each episode will last 15 seconds or more. So these are the early decelerations, right? Early decelerations are very easy to remember. I will discuss about this picture in again because it only is added in my slides to show that what is the importance of motivation only. When you are motivated in a proper way and your motivational quotient is extremely high, then nothing can stop you from gaining the success, right? This is an example for this. Now the types of deceleration, coming back to this. Early decelerations, you have already seen and I have already explained. Variable deceleration. Now, variable decelerations, what is exactly that? Are not, these all are related with the contractions. Always see the contraction first and always see them in relationship with the contraction. If you're not seeing the contraction, there is no benefit of looking the variable deceleration, whether it is early, whether it is late, whatever it is. Early decelerations are usually due to head compression. And what happens after the head compression? When the head is compressed, there is a vagal stimulation due to change in the blood flow, which lead to the early deceleration, right? And then comes the variable deceleration. Variable deceleration are not necessarily associated with the uterine contraction. This is the variable deceleration. These have no relationship with the contraction. Where the contraction is coming, where the contraction is going, this has nothing to do with that, right? The late deceleration. Late decelerations are the repetitive, periodic slowing of the fetal heart rate. Now listen, with onset, when it starts late deceleration, onset mid to the end of contraction. Onset is not with the start of the contraction. When it will start, when the contraction is reached at its mid part or when the contraction is reaches its end part. At that time, the heart rate is dipping. And the lowest point, more than 20 seconds, after the peak of contraction has gone, but the deceleration has not gone. After the 20 seconds, it's not, these timings are not necessary to remember, right? This is just for making you it more understandable. And ending for the contraction, right? And it is usually showing the uteroplacental insufficiency. You cannot look under, like, feel like late decelerations are not important, and you cannot overlook it. These are again the picture of, this is not necessary to remember, right? This is not necessary to remember when it is starting, when its nadir is coming, when it is recovering back. These seconds are totally unimportant to remember. Don't remember these things. Things are coming, which I will tell you that these are the things which are important. Now, concerning features of the variable deceleration, why I'm telling you before this, because in the next few slides, we will be discussing that how we have to make the management plan. This is the thing that you have to know very well, because otherwise variable decelerations are not important at all if they are not having any concerning features. Because without concerning features, variable deceleration have no mean at all, right? So you should be knowing the concerning features. Deceleration is lasting more than 60 seconds. This is the duration. This is the deceleration is coming. This is reaching its depth, nadir, and this is going back. This duration should be more than 60 seconds. Reduced variability within the deceleration. This is the deceleration, dip of the deceleration. Its variability is reduced, right? Failure or slow return of the baseline fetal heart rate. These are the heart rate. These are very slow to get back to its original line. This is the original baseline fetal heart rate. It is taking too long to reach there. Loss of previously present shouldering. Shouldering is a good sign, actually. Shouldering shows that fetus is recovering in between the contraction. Fetal heart rates are rising in between the contraction. When there is no shouldering, it means the CTG is now things are going bad. It means now you are concerned. When shouldering is present, it is a very good thing. There is no need to worry about. Now, please, can you, anyone can repeat the concerning features, please, so that we will remember everything over here?
If it lasts more than 1 minute and
Yeah.
it takes a long time to return, reduce variability between the deceleration, and also there's a absence of shouldering sign.
Yeah, exactly. May I know who is this?
Rekha.
Oh, yes, Rekha. Thank you so much. Okay, all right. Now, categorization of the decelerations, right? Now, let's see. White, amber, and the red. Okay. White means no deceleration, right? Or early deceleration. Or it means no deceleration is not important. Early deceleration comes in the white. White means you have to ignore everything in the scenario, right? Or variable deceleration that are not evolving to have concerning characteristics. This is the thing that I have told you. Whenever variable deceleration have mentioned in the scenario, don't bother it at all if the concerning features are not in there. Do not include it in your management plan. Variable deceleration doesn't mean at all without concerning characteristics. Then amber. Amber means repetitive variable decelerations. Repetitive means which are more than 50% of the contraction. If there are 8 contractions has been given, almost in the 5 contraction, there should be variable deceleration, right? Now, categorization, how we will categorize the CTG. Repetitive variable deceleration with any concerning characteristics for less than 30 minutes, or variable deceleration. Now come to these 2 points, this and this, right? CTG will become suspicious, CTG will become normal. This is normal, this is suspicious, and this is pathological CTG, right? This is normal CTG, this is suspicious, this is pathological. So in the normal CTG, these are the features. In the suspicious CTG, let me tell you, repetitive variable decelerations with any concerning characteristics for less than 30 minutes, right? Remember this 30-minute word. Now from this amber, come to this point. Repetitive variable deceleration with any concerning characteristics for more than 30 minutes. These two are same points in the amber and in the red. This is same, this is same. Then repetitive late deceleration for less than 30 minutes, or repetitive late deceleration for more than 30 minutes. So this guideline is very simpler version of the previous one. In this guideline, they have simplified it a lot. Otherwise, it was very difficult to remember. Now, only these 2 things you have to remember. Forget about all the story. All the rest we will discuss in after this time. But first of all, just remember these 2 words. Repetitive, now the variable deceleration, if they are not repetitive, they are not important. If they are not having any concerning feature, they are not important. They are only important when they are repetitive and when they have concerning characteristics, right? So just look at these 2 things and then look at the time. Less than 30 minutes, it is in the amber category. If it is more than 30 minutes, it is in the red category, right? So please, anyone can repeat now these 2 points, variable deceleration and the late deceleration, less than 30, more than 30. Is it clear now?
Yes, ma'am.
Okay, all right. And acute brady, everyone knows, there's no need to explain it, that acute brady or the single prolonged deceleration lasting more than 3 minutes is also a bad feature, right? We all are not happy with that. Now there is categorization of the CTG trace and the management plan. This is your EMQ is coming. Your Monicum, Rekha, everyone, your EMQs are coming from this slide, and this is the slide from where everyone is doing the mistake. Everyone is doing the mistake. That scenario is given about there, and they reach over here, 0.4. They have crossed the point 1, 2, 3, and they have reached the 0.4. They have crossed all this scenario and they reach the 0.2. So I have combined all the three categories on this slide so that you can have a pretty good idea that how we are going to manage this patient, right? Okay, let me, all right. Now the categorization of the CTG trace. CTG trace can be normal, it can be suspicious, it can be pathological. How we will decide it? There is no amber feature or the red feature. Nothing is there, it is normal. What you are going to do is CTG is normal. We will continue the CTG and the usual care. Continue to perform full risk assessment at least hourly. Now this thing have also changed. Many candidates and many students are choosing the option where there is written 2 hourly assessment, 4 hourly assessment. Let me tell you that 4 hourly and 2 hourly assessment is not for the CTG. That is the intrapartum assessment of the vaginal examination. It has nothing to do with the CTG. CTG, this guideline has told that hourly assessment will be done, even if everything is going fine. Even if the patient is pretty normal, everything is going fine, still you have to do the full risk assessment every hour and then document the findings. Please do not choose, even you have seen in the study group that many students are choosing 2 hourly assessment, 4 hourly assessment, that everything is going fine, ma'am, we have to assess 4 hourly. No, we are talking about CTG, we're not talking about vaginal examination, right? So you have to choose hourly assessment if everything is going fine. Suspicious. Any one feature is amber. Now the amber features you are knowing already, right? When any one of the feature is amber, if the CTG is categorized as suspicious, and now in the amber category or the suspicious CTG, again, there are 2 points to remember. Many students are confused over here in these 2 points. You have to see this slide as there are 4 columns. 1 column, 2nd column, 3rd column, and this is the 4th column, right? This is not the 1 column. These are the 2 columns. Why these are the 2 columns? Because in the suspicious CTG, when the CTG is categorized as suspicious, there are 2 scenarios. In one scenario, there is no concerning risk factor, right? Its management plan is different. In the other scenario, there are additional risk factors are present. In this story, the whole management plan will change, and the story will change. Story will change according to the risk factor. So, or whenever there is suspicious CTG, whenever any feature of amber, you have to look in the scenarios. Is there sepsis mentioned? Is there any evidence of meconium? They have shown that patient is not progressing well. You have to search these 3 points in the suspicious CTG. Then you will make the management plan. This is the CTG slide, which is 100% coming in MRCOG Part-2 exam. Just mark my words. This slide is coming in your exam. I have all elaborated the amber and red and white features completely so that people will be knowing in a very detail. But this is exactly the slide which is of your exact purpose. Whenever there is amber feature, look for the risk factor. If there is no risk factor, perform full risk assessment, including full set of, now they have explained, including full set of maternal observations, taking into account whole clinical picture, and document the findings. Undertake conservative measures. Conservative measures are also coming in the future, in the next few slides. Now, if the suspicious CTG and additional risk factors are present, what we have to do, we will be discuss that in detail as well, right? It is coming in the next slide. This is one scenario. This is second scenario. This is a third scenario. This is a separate, don't confuse it with the upper one. These are not the same. These are 2 different things. The fourth scenario is that if one feature is red or 2 or more features are amber, we will categorize it as a pathological CTG. So if the CTG is categorized as pathological, obtain an urgent review by the obstetrician and the senior midwife. This is the number 1 point. Usually the candidates and the students, they usually do not take it into account, and they do not bother this point in the answer options. This is a wonderful option. This is mentioned by the guidelines, so we can choose it. Only you can choose what you have to do after the pathological CTG, not directly cesarean section, not directly expediting the birth, not directly taking any decision. You can, if this option is given, first of all, you have to come this step. Usually all these steps are done simultaneously, but if any of this has already been done, then you can come to the next step, right? Otherwise, you can come to the next 3rd step. Obtain an urgent review by the obstetricians and the senior midwife. Exclude an acute event like cord prolapse, placental abruption, uterine rupture. You have to exclude this. perform a full risk assessment plus full set of maternal observations. Maternal observation full set means vitals, blood pressure, temperature, pulse, abdominal examination, vaginal examination, her antenatal risk factor review, her intrapartum risk factor review. That is complete full set of observation and the risk assessment, taking into account whole clinical picture and the document the findings. And then consider the possible underlying cause and undertake the conservative measures. Even in the pathological CTG, they have told to do the conservative measures. Then why anyone is choosing in the pathological CTG direct cesarean section? There is no point of choosing that. When they have not mentioned, we cannot choose. We cannot make theories on our own, right? We have to choose from these options only. So we have discussed about scenario number 1, scenario number 2, scenario number 3. Now this is the scenario number 4, when the suspicious CTG, but in the scenario sepsis has been mentioned, patient's temperature is raised, meconium stained liquor, thick meconium, thin meconium, or slow progress. Slow progress means patient's repeat examination has been done and patient is still far away from the progress, she's not progressing well. Then 1 point we will do as above, like perform full risk assessment, doing full set of maternal observations, taking the whole clinical picture into account and document the findings. Then we can consider the possible underlying cause and undertake the conservative measures as indicated. So here also we will choose the conservative measures. Here also we will choose the conservative measures. No need to choose cesarean section, no need to choose cesarean section in both of these options, right? Okay. So this was the point that we were discussing, that suspicious CTG and additional risk factors. What were the additional risk factors? Can anyone repeat, please?
And slow progress, meconium stained liquor.
Exactly.
One more is there, ma'am. One more is there.
Yeah. Sepsis, slow progress, and meconium, right? You have done the conservative management. Obtain an urgent review by the obstetrician and senior midwife and consider fetal scalp stimulation or expediting the birth. You can choose among these two. And this is the only thing, this is the only option you will choose in this scenario. Fetal scalp stimulation will not be chosen in any other scenario. This is the only thing that you have to choose in the suspicious CTG and additional risk factors, right? Fetal scalp stimulation only in this scenario. It will not be in the pathological CTG. It will not be in the suspicious CTG when there is no other risk factor. If CTG trace is still pathological after implementation of conservative measures, then what you have to do? Obtain a further review by the obstetrician and the senior midwife, evaluate the whole clinical picture and consider expediting the birth. If there are evolving intrapartum risk factors for the fetal compromise, then have a very low threshold for expediting the birth. Now, digital fetal scalp stimulation, what does it mean? If this leads to acceleration in the fetal heart rate and sustained improvement in the CTG trace, what we will do? We have done the fetal scalp stimulation, right? What will result of? We will see the result. We are not doing it without any purpose. We have the purpose behind it because it's going to change our decision. We have done the fetal scalp stimulation, right? And then we will see the result. If it will lead to acceleration in the fetal heart rate and improvement in the CTG trace, we will continue to monitor the fetal heart rate and the clinical picture. We will continue to monitor. We are not going to do any intervention. But absence of the acceleration is a worrying sign that the fetal compromise may be present and expedited birth may be necessary, right? So this is a very important point and it only comes in this scenario. Now the record keeping of the CTG, this can come as a single best answer question. Keep the CTG trace for 25 years. If possible, store them electronically. In case where there's a concern that baby sustained any brain injury, store them indefinitely. This is a frequently coming single best answer question, right? And this is everything is clear, friends. Please in the chat box reply me. In the pathological CTG, what we have discussed, obtain a further review, evaluate the whole clinical picture, consider expediting the birth. If there is evolving intrapartum risk factor for the fetal compromise, we have a very low threshold for expediting the birth, right? Okay. If fetal heart rate, if the decision is made for expediting the birth, ensure that the time at which urgent review was sought and the time decision was made are documented. What time you have to document? The time when your when urgent review has been sought and time when the decision was made, right? These two timings you have to mention. Okay, underlying causes and conservative measures. Yes, we have read in the previous scenario that we have to do certain conservative measures. Now, what are conservative measures we have to do? Please mute your mic, please, friends. Underlying causes and conservative measures. Start one or more conservative measures based on the assessment of most likely cause. Conservative measures you're not going to choose for without any reason, like patient is not having anything and you are going to do conservative measures on your own. No, it's not like this. Maternal position. Encourage the women to mobilize or adopt an alternative position and to avoid being supine. Right? So you have to see that what is the position of the patient. You will encourage the patient, she can get mobilized and she can adopt an alternative position as well. Right? All right. And what else? Okay, all right. And you can also see the hypotension. Hypotension. If patient, what is the hypotension? If patient blood pressure is falling, do not offer IV fluid to treat fetal heart rate abnormalities unless the woman is hypotensive. It is a common practice. Fetal heart rates are not fine, just start the IV fluid. It's not recommended. Do not offer IV fluid to treat the heart rate abnormality unless the woman is hypotensive or she has a sign of sepsis. If woman is hypotensive secondary to an epidural top-up, start IV fluid, move her to left lateral position and call an anesthetist review. So these are the things what we have to do when there is a hypotensive episode, which is secondary to the epidural top-up, right? So after the epidural top-up, patient blood pressure is falling, you have to choose these three options: IV fluid plus move to the left lateral plus call the anesthetist. These plus you have to choose these three options, the option where these three have been combined, right? Excessive contraction frequency. Reduce contraction frequency, but reducing or stopping the oxytocin if it is being used. Yes, if the contraction frequency is more, like you have already seen that 5 or more contractions, right? Or the contraction is lasting more than 10 minutes, then definitely lasting more than 2 minutes, then definitely you have to reduce the contraction frequency. How you have to reduce the contraction frequency? You have to reduce the contraction frequency by stopping the oxytocin if it is being used or by reducing it. And then you will offer the tocolytic drugs. Subcutaneous terbutaline is recommended in the dose of 0.25 milligrams. Do not use maternal facial oxygen. Everyone knows it that these are no more recommended, right? So any question up till now, everything is clear, my